Assalamu alaikum. Today we are going to discuss a very important topic in laparoscopy. I would say it is of importance to every specialty, whether general surgery, pediatric surgery, gynecology, or urology, because this is the basic of laparoscopy, and we are discussing the effects of pneumoperitoneum on the body, and the response and the physiological response of the body to creation of the pneumoperitoneum. So this presentation is divided into the following headings: the physiological consequences of pneumoperitoneum, monitoring tools, how to monitor all these physiological consequences, what are the contraindications, and what are the indications. The first thing in pneumoperitoneum or any surgical treatment is the anesthesia. So in laparoscopy, we generally prefer general anesthesia, as we are talking about the transperitoneal approach here. So general anesthesia must be given, and muscles should be properly relaxed, because if you find that it's difficult to create a pneumoperitoneum, or a small amount of gas has produced a lot of pressure, it means that the muscles are not properly curarized. So a tracheurim is usually given, and when there is complete relaxation, one must wait for it, because if the muscles are not completely relaxed and you are trying to create a pneumoperitoneum, this can invoke vasovagal response, leading to tachycardia and a lot of problems. So proper time should be given for adequate muscle relaxation, and the position especially in urology is usually a non-physiological position, because we perform most of the procedures like nephrectomy, radical nephrectomy, pyeloplasty, pyelolithotomy, partial nephrectomy, adrenalectomies. We perform them in lateral decubitus position. So the position is not physiological. Or if you are performing pelvic surgeries like ureteric reimplantation, vaginal fistula, and prostatectomy, radical cystoprostatectomy. So all these are non-physiological positions. So they create a lot of problem. And during this process, as you know, that the camera is lying on the foot end of the patient, the suction machine, the diathermy machine, the assistance, the surgeon towards the head of the patient. All this makes the patient inaccessible to the anesthetist. Like, for example, if suddenly he or she needs to place a central line, the patient is inaccessible. Or if the tube needs correction, the endotracheal tube, it needs correction, it is usually inaccessible. And if there is any airembolism, it is really difficult to treat it, because the patient is inaccessible to the anesthetist as compared to in open surgery. And talking about the robotics and sophisticated things, the patient is even more inaccessible, because a lot of robotic arms are surrounding the patient, and the patient is usually lying in another room. So here you can see in the figure what I mentioned, that the surgeon and the assistant, they are standing towards the head end of the patient. The patient is in Trendelenburg position. So it is all surrounded, and you can, on the one side, you can see an anesthetist who is standing away from the patient. So if the patient requires urgent attention, he is usually inaccessible. Transperitoneal and retroperitoneal approaches in laparoscopy. The transperitoneal approach is the most commonly used approach. I personally also like transperitoneal approach. I have got my own reasons, because the cavity is usually large, so you have a lot of space to work around, to play around. You have a lot of space. So while in the retroperitoneum, there is limited amount of space, and that space too you have to create. It is not a natural space, and it is not a physiological space in the retroperitoneum. And there is a lot of raw surface when you create. For example, while performing partial nephrectomy retroperitoneally, you will be creating a lot of rough surface. So there will be more absorption as compared to the transperitoneal pneumoperitoneum, where it is naturally lined by the epithelium. So there is absorption of carbon dioxide, but it is less as compared to the retroperitoneal approach. Okay, what is pneumoperitoneum? Pneumoperitoneum means there is air or some gas in the peritoneum, and there are a lot of gases. However, we are using carbon dioxide because of a few things. Because it is highly soluble, it can get absorbed, but it can really be ventilated through the respiratory system. So it is more soluble than any other gas, and so it dissolves into the air and can be pushed away from the body, as compared to other gases who, if they get absorbed, it is difficult to get them externalize them from the body. So it is really very safe. It is non-combustible. You can use any energy source in carbon dioxide. It is usually stored in the form of liquid, and that is under tremendous compression. So when the gas converts from liquid into the gas form, it is really very cold. So it is there is no contamination. Literally no bacteria or virus can survive those cold temperatures. So it is highly sterile and is non-contaminated, and the visibility through it is really very good. So it is transparent, and visibility is good. So these are the properties of carbon dioxide. And in this presentation, we will be picking each system and see the effects of this pneumoperitoneum on the body. That is cardiovascular system, respiratory system, renal, neurological, as well as mesenteric systems. Pediatric and adult, as I said, that pediatric elasticity is higher than in the small children or the adults. You can see the normal things. The oxygen consumption in children is more. However, there is a particular thing that their vagus nerve is more sensitive as compared to the adults. So whenever you are creating a pneumoperitoneum and you see that there is tachycardia, you should immediately remove all the gas, because that means that there is vasovagal stimulation, and that may lead to tachycardia, bradycardia, and cardiovascular complications. So you have to really be very careful, and you will need very small amounts of gas, because the abdominal cavity is very small. So less amount of gas will be used or required to create the same pressure. In adults, we usually work around in a normal individual with a 12 millimeter of pressure. However, in pediatric age group, 6 to 8 will be more than enough, and above 8 will usually get complications. So stay below the 8 millimeter. So what are the effects on pulmonary system? So you can just think that there can be two things. Number one is mechanical pressure of the gas. The gas is actually, it is pressure, so it is pushing everything. It is pushing against the abdominal wall, because you want abdominal wall to distend, so that you get a lot of cavity. So there are 5-6 dimensions of this abdominal wall: the pelvic cavity, the diaphragm, the posterior abdominal wall, the lateral abdominal walls, and the anterior abdominal wall. So elevation of the diaphragm will be actually occurring because of the mechanical pressure. So this mechanical pressure will actually reduce the functional residual capacity of the lung, because lung can now not expand as much as they would in a normal condition, because diaphragm is forcefully being pushed towards the chest cavity. So they have to work against the resistance. Thus the functional residual capacity is reduced, and this reduced capacity is further reduced when the patient is lying in a lateral decubitus position, because the lower lung has got all the supply, so it is congested and the diaphragm is pushing. So the functional residual capacity is really reduced. And in Trendelenburg position, everything is pushing down, the head end of the patient is down, so that will also reduce the functional residual capacity. So there will be reduced lung compliance, and there will be increased airway resistance, and there will be increased physiological dead space. I would say that there is ventilation perfusion mismatch. The lung is expanding, and that too is expanding against high resistance, so it is not expanding fully, and there is pressure on the lung, so there is more dead space because the expansion is not getting ventilated. So this physiology is really important for the anesthesiologist to understand, depending upon the position, whether patient is in supine position, in a lateral position, or in a Trendelenburg position. The anesthetist must be aware of this, and the anesthetist must know if there is hypercarbia, if there is retention of carbon dioxide due to this pulmonary effect, then he has to increase the rate of respiration to compensate for the retention of carbon dioxide. So to restore the end-tidal carbon dioxide to baseline levels, an increased minute ventilation must be needed. That is, the respiratory rate needs to be increased. And to clear the excess carbon dioxide, a longer post-operative ventilation can be a necessity in some patients, like for example in old age, in COPD, asthmatic patients. So the patient may take a little longer to recover as compared to those in a normal surgical conditions. So here you can see the same repetition. There is a reduced pulmonary impact is shorter. So there should be a really good communication between the anesthesiologist and the surgeon, because the anesthetist can increase the rate, and it can give a positive pressure ventilation as well to reduce the carbon dioxide within the blood and hypercarbia. However, the surgeon, what he can do is that he can reduce the impact of these effects on the lungs by performing a shorter procedure. So a shorter operative time and a lower abdominal pressure will have decreased pulmonary impacts on the physiology. All these effects that have been discussed in the previous slide, they are reduced by shorter operative time as well as by reduced intra-abdominal pressure. If you can perform a procedure at a pressure of 8, see if you can perform a procedure at a pressure of 10, then don't go for 12 or 14, just try to stay at 10. If you can perform it at 8, don't go for 10. So if the patient is for that matter overweight, the abdominal wall is really thick and heavy, yes, of course you have to go for 14. But if you can perform it in 12, don't go for 14. Okay. This slide has already been discussed. There is lung bases being compressed because of the pressure, and it leads to decreased compliance and decreased functional residual capacity, and increased positive inspiratory pressure, and there is ventilation perfusion mismatch, and there is an increased dead space ventilation. So carbon dioxide can usually occur, and this may lead to increased shunt fraction like hypercarbia as well as hypoxia, and this can affect the brain, leading to cerebral edema, which can further lead to various physiological effects. Now coming to the cardiovascular system, what is the effect on the heart? Again, there is mechanical and hormonal effect on the heart. So number one, the mechanical effect is that the inferior vena cava is being compressed by the increased pressure. So if the vena cava is compressed, there is decreased venous return to the heart. This decreased venous return can lead to decreased output, cardiac output, and that can lead to hypoxia and reduced, of course, tissue oxygenation, leading again to lactic acidosis and hypercarbia. And another important thing is the humoral. The humoral effect is that when the cardiac output is decreased, So there is a release of hormones. So that leads to vasoconstriction, and this vasoconstriction leads to increased vascular resistance, which can further hamper tissue oxygenation. So here is the sequence of events. So there is decreased cardiac output by 10 to 15%, and this is because of the decreased venous return, and this is because this leads to increased mean arterial pressure, and there is increased systemic vascular resistance because of the hormones. So there is increased central venous pressure, and this is due to catecholamines, prostaglandins, and antidiuretic hormones. This antidiuretic hormone secretion can increase to 500% in a patient undergoing a pneumoperitoneum. So depth of anesthesia must be really good to combat all those things. So it's really very simple: mechanical effect and humoral effect. Mechanical effect leads to decreased venous return, increased mean arterial pressure, decreased cardiac output. This leads to release of the catecholamines and all the vasopressins, and release of these leads to vasoconstriction in the arteries, which can lead to increased systemic vascular resistance, and thus further tissue hypoxia, leading to lactic acidosis as well as retention of carbon dioxide. So one specific complication during pneumoperitoneum is bradycardia, especially in pediatric patient, and this is vasovagal, because they have a higher vagal tone as compared to the adults. So peritoneum is stretched, that leads to stimulation of the vagal nerves. So when that happens, immediately decompress the peritoneum. Now we come to the renal system. The renal vein is compressed as well. So there, the parenchyma and the renal vein that gets compressed, and that leads to decreased flow in the kidney, which is going to cause decreased filtration rates. So there is going to be oliguria, and there is release of antidiuretic hormone. As I said, it can increase up to 500% as compared to the normal condition. So that leads to oliguria, decreased urine output. However, research has shown that it does not have any impact on the post-transplant graft outcomes if laparoscopic donor nephrectomy is performed, and one should not even try to treat it, because it's a physiological condition, and it usually reverses within 12 hours. And if you treat it, you may over-treat it, and that can lead to fluid overload. So there is impaired regional blood flow, 10% of reduced urinary output. This reduced flow can be 30 to 40%. So don't treat it. There's impairment of physiology. The release of vasopressin also leads to renal vascular resistance, and antidiuretic hormones are released, which lead to decreased urinary output. Here there is a simple table. You can see that there is increase in the intra-abdominal pressure, which leads to decreased cardiac output, and this decreased cardiac output in turn reduces the renal plasma flow, which gives reduced GFR. And the direct effect on the kidney is the mechanical as well as hormonal. So the mechanical, there is venous compression, the parenchyma is compressed, there is stimulation of the CNS and baroreceptors, which leads to antidiuretic hormone secretion, and there is hormonal stimulation, there is increased cardiac, there is increased level of carbon dioxide in the blood, which leads to decreased pH of the blood, and all these things lead to release of epinephrine and norepinephrine, and thus renin-angiotensin mechanism is stimulated, and it leads to vasoconstriction, and this vasoconstriction again leads to decreased plasma blood flow and decreased urinary output. So there is compression, mechanical compression, and hormonal, both effects. Then comes the neurological system. There is increased intracranial pressure and decreased cerebral perfusion. So there is hypercapnia, and there is increased systemic vascular resistance, and there is raised intra-abdominal pressure. The head position is down in the Trendelenburg position, as well as in the lateral decubitus position, and that leads to cerebral edema that can further give cardiovascular effects. So here you can see that these are the physiological consequences of carbon dioxide. So you can see that there is increased intra-abdominal pressure, which leads to decreased venous return, increased intrathoracic pressure, increased vascular resistance in the abdominal organs. There is increased venous resistance as well. And that leads to release of vasopressors, which again leads to increased systemic vascular resistance, so the cardiac output is reduced and arterial pressure is increased. So what happens to the mesenteric circulation? Again, compression as well as hormonal effect. So due to compression as well as all the hormones previously discussed, vasopressors, they lead to vasoconstriction. As in shock, you can see that the first organ in the body that is affected by vasoconstriction is the gut. So there is a splanchnic vasoconstriction, there is hypoperfusion to the gut, and this hypoperfusion can lead to bacterial translocation and later on septicemias. And there is raised arterial resistance, which leads to decreased perfusion and tissue hypoxia, again bacterial translocation. And post-operatively, all these things may be noted. In some patients, the bowel sounds come early if the procedure is shorter, and in some cases, the gut motility can be delayed. So this may lead to nausea, vomiting, or loose motions. Here you can see another diagram, flow chart. So there is hypercapnia, release of vasopressin leading to increased vascular resistance in the splanchnic circulation. Decreased cardiac output also leads to splanchnic circulation resistance increase, and the superior mesenteric artery blood flow, mesenteric microcirculation is decreased. So there is decreased effective perfusion, and there is reduction in gut metabolic activity, splanchnic ischemia, bacterial translocation, and there is also ischemic reperfusion injury when the procedure is complete and the abdomen is decompressed. This can lead to reperfusion injury. The metabolic responses of the body are: there is stimulation of the central nervous system, which is due to sympathoadrenal system, because adrenal gland is also compressed, and that leads to release of adrenaline and noradrenaline, which may increase the heart rate, and the blood pressure may be increased. And there is inotropic effect of these hormones. So again, it will lead to increased heart rate and increase in blood pressure. And there is bronchoconstriction, there is vasodilatation, and there is increased cerebral blood flow, which results in cerebral edema. And there is hypercapnia, which again leads to and decreased pH, which all of them contribute to cerebral edema. This is again the same. All the flow chart, you can just take a screenshot from it, and then you can see them in detail. We have already discussed all these things. So here, this diagram is a beautiful representation of all the physiological compromises in pneumoperitoneum that we have discussed previously on all the slides. You can see there is heart, there is inferior vena cava, there is kidney, liver, spleen, there is gut, small bowel, large bowel, and everything has been shown. So you can see lungs. So you can see that there is an increased systemic vascular resistance. There is a increased intra-abdominal pressure, which is against diaphragm. It makes breathing difficult. Decreased gut perfusion, decreased wound perfusion leading to poor wound healing. lower extremity deep venous thrombosis can be really a big risk in such conditions when the inferior vena cava is compressed. So there is vena caval compression, there is decreased preload and afterload, there is decreased cardiac output, and there is decreased urinary output. And this is the final outcome of all the things that we have discussed. It is nothing to worry about, but the thing is that the surgeon, as well as his team or her team, and the anesthetist must be aware of all these conditions, so that they can really cope with any inadvertent situation if it occurs because of that. Because if you don't have even the knowledge of it, you may not even know an event can happen, and then later on you think what was happening and all those. So it is not to frighten the people who are doing laparoscopy, or trying to learn laparoscopy, and are trying to pursue their future careers in laparoscopy, but it is a thing which emphasizes that you must know about your procedure, about the collateral damage that you are performing, that you are causing. So, and you must know all your machinery, you must know the insufflator, you must know your energy sources and everything, so that if anything bad is going to happen, you can prevent that. Now we come to the special situations in pneumoperitoneum. By keeping all these in mind, the effects on the pulmonary system, the renal system, the central nervous system, the splanchnic circulation, the intrathoracic system. Now let's see what we are going to implement practically. So if we are performing a procedure on the kidney, so the patient has to be in the lateral decubitus position, and sorry, so the lesser pressure is required in lateral decubitus position. The reason being that half of the abdomen is already filled by the content of the gut, small bowel, the large bowel, all if the patient is in the lateral position. So half it is going to drop everything into the lower half of the abdomen. Now you have a smaller space to work, so a lesser pressure would be required. But it is more problematic for the anesthetist, just because of the position, because if he needs a central line, if he needs to correct the tube, if he needs to treat the airembolism, the patient is in the lateral position, it is difficult for him to cope with. And this position has a profound changes in the cardiovascular system, and if the patient is already taking a beta blocker, then it's really difficult for the patient to respond to physiologically to this position. So the pressure effect is on the diaphragm. It leads to compression of the lung bases, and thus an area which is perfused but not ventilated. And there is raised intrathoracic pressure, which may also affect the heart. And this is the lateral decubitus position. Here you can see that the patient is really overweight, and thus the patient is placed right on the edge of the table, so that the belly drops down and it takes away most of the small bowel and the large bowel away, and thus space can be created to work. But the patient is in a straight position. This is the position that I like. I do not break the table. So what about the Trendelenburg position? We all know that this position is made for a procedure which are performed in the pelvis, like ureteric reimplantation, like vesicovaginal fistula repair, like transvesical prostatectomy, like Millen's prostatectomy, like radical cystoprostatectomy, radical prostatectomy. So this position is usually achieved. So while making position, do not fix the patient to the table, as it may lead to skin ruptures and neural bundle injuries. Do not fix the patient or his skin or her skin. Always wrap around the arms and the legs, and then fix those those wrappings to the table rather than the skin, because weight of the patient may be, if the patient slips, the weight of the patient may lead to breakage of the skin. And do not apply tapes over the chest area, or the because of the compression, there will be eyelid edema because of the head down position. And do not tie the legs, that can lead to deep venous thrombosis. Always tape fix the cushions rather than the skin. All the areas where there is increased pressure on the body, they have to be padded with some cushions. Better if there is gel cushion. So the venous return is better, the pressure is increased, so there is no problem with the cardiac output. However, this position is really well tolerated, and there should be wrappings around the arm. So this is the position. Here you can see that the legs have been tied over the over a wrap, and the arms have been tied over the lap, over the wraps, and the chest is not tied to the table. And you can see a specific cushion around the shoulder, which is preventing the patient from slipping down. However, this cushion can at times be very dangerous, leading to brachial plexus injuries. So here you can see how the legs are taped and how the arms are taped, and what is the position, and what cushion should be used around the shoulders, so that it supports the neck as well, and it is supporting both the shoulders rather than one shoulder. And because this can lead to, if a proper cushion is not used, this can lead to brachial plexus injury, the ratchet phenomena. So what about the extraperitoneal insufflation? Less gas is required, but the pressure is usually high. So there is a small area, but all area is raw, so there is more absorption of gas, because there more pressures are created, higher pressure are created, more raw surface, which is absorbing more gas as compared to the transperitoneal. So this more absorption of the gas can lead to hypothermia, and this hypothermia can lead to increased infections, increased risk of bleeding, as well as the patient can at times feel that he was awake. So humidification of the gas is the solution for all this, to avoid hypothermia. So we now know what are the effects of pneumoperitoneum on the body, and what is the response of the body to that pneumoperitoneum. So in order for the effects of the pneumoperitoneum and for the physiological retaliation of the body, there has to be a line of normalcy and abnormalcy. So if that line is crossed, we have to do something. So how can we know what is that line? So for those, we are usually using the monitoring tools, and the monitoring tools are as shown in this slide. So number one is the arterial line. So it gives you a tight control of the arterial pressure or the mean arterial pressure. You can take ABGs and see what is the pH, what is the concentration of oxygen, what is the concentration of the carbon dioxide, and then you can see whether that line is crossed or not. If that line is crossed, then you have to do some maneuvers. Then is the CVP line, is another monitoring tool. It can give you indication about if there is heart failure, and if there is gas embolism, you can even treat it with the CVP line. Of course, ECG, blood pressure monitoring, pulse oximetry, and capnography in laparoscopy is implemented in every case. And there is peak airway pressure, there is intra-abdominal pressure, the insufflator is talking to you constantly, and you can see the urinary catheter for any bleed or output you can measure per hour. So these are the monitoring tools, and they can be used. What are the indications? What are the risks and benefits? It is really very clear that duration of procedure has got a really very important impact on the effects of pneumoperitoneum. Shorter duration, smaller effects. Longer duration, more effects. And it is not mere responsibility of the anesthetist to look for all those things. It is not the mere responsibility of the surgeon. It is basically in equal responsibility of both the surgeon and anesthetist to take care of the patient while pneumoperitoneum is there. So there should be volume controlled ventilation. The tidal volume can be increased. The frequency of respiratory rate that can be increased, and the time between inspiration and expiration that can be prolonged. And this is the case for the anesthetists rather than surgeons. And if there is any need, if there is retention of carbon dioxide, or if there is some patient factor, pressure controlled ventilation can also be implemented by the anesthetist, because it is very good for the obese patients, and positive pressure ventilation is performed to avoid any alveolar collapse. So there is no ventilation perfusion mismatch. As we all know, that pressure on the diaphragm can lead to compression of the alveoli. So that area is perfused, but it is not ventilated. So for that, the anesthetist can use a positive pressure ventilation. Now we come to the contraindications. In the modern world, with all the sophisticated monitoring tools, the contraindications to laparoscopic surgery or the pneumoperitoneum has decreased down to very few conditions. And those would be contraindication to any general surgery, any kind of surgery. But the particular contraindications are here is that if the intracranial pressure is high, one must avoid creating pneumoperitoneum. If, for that matter, because of the intracranial pressure, ventriculoperitoneal shunting has been performed, because if there is ventriculoperitoneal shunt placed in, all the gas and all the pressure will be transmitted to the ventricular system of the brain, leading to brain injury. And if there is history of any spontaneous pneumothorax, then laparoscopy and pneumoperitoneum has to be contraindicated. In cases of acute glaucoma, it should be avoided. A chronic treated glaucoma, one can go for laparoscopic surgery. However, acute glaucoma is an absolute contraindication. Coagulopathy is in any case is a contraindication. If there is hypovolemia, first treat the hypovolemia, and then you can can create a pneumoperitoneum, because pneumoperitoneum in hypovolemia is going to further compromise the cardiovascular system. So what are the indications in cardiovascular system? Ischemic heart disease previously used to be a contraindication, but now it is not a contraindication. Just one important thing is that you must have a cardiac center and a cath lab available in the near vicinity, so that if there something bad happens, you have the facility to do an angiography and an angioplasty. Of course, clopidogrel has to be stopped a week before. I usually prefer to stop them 10 days before surgery, and aspirin does not need to be stopped. However, if you want, you can stop it 3 days before surgery. In pulmonary conditions, restrictive airway diseases like in atelectasis, and if there is obstructive airway like chronic obstructive pulmonary disease, then of course it is contraindicated. However, in asthma, it is nowadays not contraindicated, because you can give bronchodilators during the procedure, before the procedure, and after the procedure. Obesity once was a contraindication because it has mechanical consequences, and the problem with the obese patients is that you have to create more higher pressure. So a lot of gas is going to get used, and there has to be, because the thicker the abdominal wall and the more pressure it would need to lift it up. So that pressure is going to transmit to the diaphragm as well, leading to some pulmonary condition. So if a patient who is elderly, who is also having ischemic heart disease, who is also having COPD, and he's obese as well, then of course laparoscopy may be a contraindication. So here we can see that these are the relative conditions, the CNS diseases like we have already discussed, vpshunt, renal failure. Renal failure, a lot of research has shown that patients who are end-stage renal disease or those who are a chronic renal disease, they fare better by undergoing laparoscopic nephrectomies as compared to open nephrectomies. However, the oliguria cannot be called a renal failure because it is going to reverse from 12 to 48 hours. And if there is any history of course, abdominal surgery, there may be airembolism or bowel injury that has to be taken into account. Thank you very much for listening patiently. I will produce another lecture of the same, which will be a little shorter and more concise. See if you like that one as well. Thank you very much.